Good morning, good evening, good afternoon, wherever you are. I want to welcome you to this live session today. My name is Patrik Hutzel from intensivecarehotline.com, and I'm here today to answer all of your questions. If you have a loved one, a family member in intensive care. If you're new to this, you may want to know why am I doing what I'm doing. Give you a little bit of background. I worked in intensive care for 20 years in 3 different countries. I worked as a nurse unit manager in intensive care for over 5 years. I have looked after thousands of critically ill patients and their families in intensive. And I have been consulting families in intensive care now for over 5 years. There is no intensive care that I haven't seen before. I understand intensive care inside out. I know the dynamics, I know the politics, I know how intensive care units operate, and I know it probably all too well. I know the questions that families in intensive care have. I know the questions that families in intensive care are afraid to ask. And I also know that the intensive care team or intensive care teams in general are usually very indirect in answering questions, whereas from me, we take away all the fluff, and from me you get the straight answers that you don't get in intensive care, because they're often trying to cushion the answers without, telling you straight what's happening. So today in particular, I want to talk about when to remove the breathing tube or when to do a tracheostomy. In my last live session, I was talking about, the 4 main areas that families in intensive care struggle with. And those areas are, generally speaking, end of life, removal of the breathing tube or when to do a tracheostomy, number 3, and not waking up after an induced coma, and number 4, head and brain injuries. So today I want to mainly talk about when to remove a breathing tube and when to do a tracheostomy. If you have any questions, you can type those questions in the chat pad, or you can also call me directly and we can discuss your questions live in this session. So I'll type in my phone numbers here. It's 415-915-0090 if you are in the USA or in Canada. My number, if you are in the UK, is my number for the UK is 0118-324-3018 if you're in the UK. And if you're in Australia or in New Zealand, my number is 041-094-2230, and you can reach me on those numbers now live. But without any further ado, today I want to talk about breathing tubes in intensive care, when to remove them, when to do a tracheostomy if a breathing tube can't be removed. So a lot of patients in intensive care end up with a breathing tube in their mouth. They end up on a mechanical ventilator because of their critical illness. When patients end up with a breathing tube in intensive care, 99% of the time it goes hand in hand with an induced coma. The induced coma is necessary because ventilating somebody with a breathing tube is very uncomfortable. It's very painful. That's one of the reasons why an induced coma is necessary. But one of the other reasons is, what goes hand in hand with a critical illness is that, your loved one's body needs to be put in a state of rest. So they can actually recover. Now that comes with numerous side effects. If you think about it, you don't want to be induced into a coma, your body's resting, that's all fair enough. But on the other hand, there are massive risks like muscle tone wastage. So then, when somebody's waking up after induced coma, it takes a long time for them to recover because they've been basically asleep for a period of time, period of days, sometimes weeks. So you can also imagine that when you take somebody out of an induced coma, and the induced coma is usually induced with sedatives, sedatives such as propofol, midazolam, Versed. I don't want to get too medical here, but it's probably good if you've at least heard those terms, because if you are going to the bedside in ICU to visit your loved one, you may see some of the medications running, and you might wonder, oh, what's that propofol? What's that midam? What is it? They are sedatives. One propofol is short-acting, midazolam is long-acting. Then also there are opiates given. Opiates are usually given for pain relief, such as morphine or fentanyl, mainly in intensive care. And again, they come with side effects, and some of the side effects are quite counterintuitive to what you're trying to achieve. Some of the side effects for fentanyl and morphine are respiratory depression, which means it inhibits a physiological breathing effort or physiological respiratory drive, which is getting very tricky, especially if you want to wean somebody off the ventilator. So when can somebody come off the breathing tube? Well, they can come off the breathing tube, if they've been over the worst of their critical illness, their lungs seem to work again, their heart seems to work again, maybe the kidneys are working again. And then the next step is to reduce or remove sedation, either gradually or switch it off completely, switch off the opiates, or reduce them gradually, such as morphine or fentanyl. And once that's done, assess if your loved one can wake up, and assess if they can breathe by themselves. Most of the time when somebody's coming into an induced coma, they're getting ventilated by the ventilator in a full control mode, which means the ventilator is doing all the work. And then as you wake somebody up, they're expected to do more and more of the breathing themselves. So when that's happening, you listen to a patient's chest, and you listen whether there's enough and equal air entry. You look out for oxygen saturation, which should be above at least 92, 93, ideally 94%. You check chest x-rays. You check arterial blood gases. You check the neurological function of your loved one, which means, are they responding? Can they do simple things like squeezing fingers? Can they blink their eyes if you ask them to? Can they wiggle their toes if you ask them to? Can they cough? Can they take a deep breath if you ask them to? Other things you'd be looking for when taking out a breathing tube is, if your loved one is taking a deep breath, is that breath adequate in volume? Which means if an 80 kilogram person is taking 400 mils, 500 mils per breath, is that adequate? And the answer is yes, it probably is not quite adequate. Needs to be a little bit higher. And if so, if the volume is adequate, does that match the arterial blood gas result, right? Is PO2, the oxygen levels in the blood, and CO2, carbon dioxide level in the blood, adequate and physiological, so somebody can be taken off the ventilator? So if all those questions that we just talked about are answered with yes, then, next step might be to remove the breathing tube, okay? But there is also a time window that's sort of limited when you take out a breathing tube, and it's got to be at the right time, right place, right hours of the day. You don't want to take out a breathing tube at 2 a.m. Ideally you do it in the morning, so you have all the support around that this patient needs to consequences of that. And those consequences, 9 times out of 10, are not that great. You don't want to put somebody on a ventilator if it's not necessary. So if then extubation happens, and somebody can stay off the ventilator, well, you put them on a little bit of oxygen. They might need a nebulizer, a saline nebulizer. They definitely need to be encouraged to do deep breathing, to do coughing, and that can be a challenge sometimes depending on the nature of the critical illness. For example, somebody having open heart surgery, having had their chest cracked open, right? Taking some deep breaths after they've come off the ventilator, after they had open heart surgery, it's quite a challenge. And they need to be well pain controlled, and often, again, pain controlled with drugs like fentanyl, morphine, endone. They are opiates, and they inhibit respiratory drive, which means it's a fine line for somebody with critical illness, with pain, getting off the ventilator and then continue to make the effort to continue to breathe adequately so they don't need to go back on the ventilator. So on the one hand, they need to have their pain controlled with opiates that have as a main side effect respiratory depression, right? And on the other hand, they need to keep breathing. So that leads me then, what is going to happen if extubation fails, or if extubation fails, or if your loved one can't be extubated in the first place because the signs are simply not there that they would the signs are there that they would fail extubation, which means they couldn't breathe by themselves and they would have to be put back on the ventilator, which probably would cause more damage than maybe moving them onto a tracheostomy straight away. So what are the timelines? So the timelines are about 10 to 14 days before a tracheostomy is done, right? You wouldn't want to rush into a tracheostomy at the same time. It's the right thing to do for somebody that can't be taken off the ventilator for a number of reasons. And then, let's do a tracheostomy, which basically means removing the breathing tube in the mouth and putting a tube into the neck. That is much easier to tolerate, right? Tracheostomy is much easier to tolerate for a patient compared to a breathing tube. It's very comfortable. You can switch off sedation straight away, and patients can be weaned off the ventilator quicker, or at least it gives them the time to be weaned off the ventilator in their own time. But often what I've seen over the many years is, as soon as you do a tracheostomy, you wake patients up from the induced coma because now they can tolerate the ventilation, and you can try and take them off the ventilator for the first hour, see what happens, right? You can always put them back on. It's very easy, much more easier to tolerate compared to the breathing tube. And then it's easier to mobilize a patient with a tracheostomy, right? You can get a patient out of bed with a tracheostomy, much easier to do compared to the breathing tube. If the breathing tube dislodges, it can be dangerous, can be life-threatening. Whereas if a tracheostomy dislodges, yes, it can be life-threatening as well. However, it's much easier to deal with it, generally speaking. Then here's a word of warning, though, for a tracheostomy, especially for our audience in the United States. So when patients get a tracheostomy in intensive care in the United States in particular, the ICUs often want to send patients on to LTAC, which stands for Long-Term Acute Care Facility. Now, LTACs claim that they're the experts on weaning patients off ventilation and tracheostomy. Now, from my experience, that's unfortunately not the case, and you've got to be very, very mindful that a lot of ICUs in the US use the tracheostomy to send patients out of ICU as quickly as possible, whether they're ready clinically or not. Now, you've got to put this in perspective. Critically ill patient in intensive care needs the specialist skills of intensive care doctors, intensive care nurses, intensive care physiotherapists in the US in particular, and in Canada there's respiratory therapists as well. If you go to LTAC, or if your loved one goes to LTAC, those skills are not there, right? So it's often LTACs are designed, in my experience, to save money and to empty ICU beds. They're not designed around clinical realities and not designed to provide care around clinical needs. That's dangerous. That is dangerous. I cannot tell you how many people I talk to every week that say, look, my loved one has gone from ICU to LTAC and it's a disaster. Help me to get my loved one out of LTAC. Now, we have helped people get out of LTAC, but it's very difficult. You should keep your loved one in intensive care in the first place, and you should get informed about what to do to keep your loved one safe and ensure they're getting the best care and treatment, because then care, and as soon as something goes wrong, they either don't get the right treatment and they deteriorate, or they bounce back to ICU, defeating the purpose of leaving ICU in the first place, right? So, as I always say, the biggest challenge for families in intensive care is that they don't know what they don't know, right? It's such a highly specialized area. If you have a loved one in intensive care, it's like walking into a minefield. You don't know what to look for. You don't know what questions to ask. You don't know how to interact with the intensive care team. You know, they are running their agenda 24 hours a day, 365 days a year, and that agenda doesn't necessarily mean it's all in the best interest for your loved one. There's politics, there's money, there's clinical research. There are too many moving parts for you to understand, are they doing everything they can to help your loved one? And again, after having worked in intensive care for 20 years, I know the ins and outs, and I can read between the lines very quickly. I can help you to ask all the right questions. And you know, the ideal scenario is to move towards weaning as quickly as possible, right? But here is a word of warning again. You know, you think about it. Somebody having the breathing tube removed, they often then go to a hospital ward, leaving intensive care, because you know they're not on life support anymore. They can go to hospital ward and they can continue on their path to recovery. Now, you think about it again, especially in the United States, not so much in the UK or in Australia or in New Zealand, but I keep focusing on the US for now. If somebody gets a tracheostomy and ends up in LTAC, long-term acute care. Now imagine, what does that imply? What does long-term acute care facility imply? It implies long-term care. Now let me ask you this. Why would anybody in their right mind send somebody to long-term care if short-term care might be an option? And what do I mean by that? What I mean by that is, we have worked with dozens and hundreds of clients that sit on the brink in ICU. The ICU team is telling them, look, we got to do a tracheostomy and we got to send your loved one then to LTAC. And we're finding the ICU team hasn't tried everything to have the breathing tube removed in the first place. You need to make sure that the ICU team is doing everything beyond the shadow of a doubt to remove that breathing tube before they even consider tracheostomy. Again, the reason for that is simple. Tracheostomies are often designed to provide long-term care, right? Especially in the US. That's crazy. That is crazy. You want to move towards the shortest path of recovery possible. And at that critical point where you either do a tracheostomy or you move the breathing tube, the recovery path for both situations is a difference like day and night. Difference day and night. Take the breathing tube out, leave intensive care, go to a hospital ward and continue recovery there, or do a tracheostomy and then go into long-term acute care and go into long-term care. It's already implying that it'll take a long time, right? And it's that critical point when you can take out a breathing tube that'll make all the difference. And I have seen so many situations where the intensive care team has not tried everything within their power to remove the breathing tube in the first place and avoid the tracheostomy and shorten the recovery period for patients. So what do you need to do to make sure that the breathing tube can be removed and that the intensive care team is doing everything within their power so that they can remove the breathing tube? Well, there is an article around that. I wrote an article and I made a video about that I will put in underneath this video shortly, right? So that's one way to remove the breathing tube. But again, the best way and the quickest way is, if you are in a situation like that, to talk to me directly, to call me on one of the numbers, and then I can show you what we need to do to get the breathing tube removed, what questions we need to ask. Again, the devil is in the detail. I can break it down for you and also talk to the doctors and nurses and holding them accountable for their actions. You know, one of your challenges as well is that you don't know how to talk to the doctors and nurses to get what you want, to ask all the right questions. That is so important, that you ask all the right questions and that you know how to manage the doctors and the nurses, that you're not intimidated by them. And again, that's where our area of expertise is coming in as well. What I do next is I'll just type into the chat pad, or I'll just send the link into the chat pad about how to wean a critically ill patient in intensive care off the ventilator, the breathing tube. It's a very important article and video that you can use as a guidepost and where you can ask questions. But again, we've helped so many families in intensive care to avoid the tracheostomy, avoid long-term care, shorten the recovery path for their loved ones by weeks and months, and potentially saving their lives. Because imagine you're going into long-term acute care, the mortality rate there, from my experience, is pretty high. It's just not the right environment. It's a dead-end environment. You know, where all of a sudden you go from intensive care 1-on-1 nursing or 1-to-2 nursing, and then you go into LTAC with 1-to-5 nursing, and they're not ICU nurses. It's dangerous. To look after tracheostomy, to look after mechanical ventilation, you need the skills and the training of an intensive care nurse to manage life support, right? Again, LTACs are designed to save money. It's not about clinical need. It's around saving money. And that's just simply dangerous. Another alternative you can consider is if you have a loved one in intensive care and you are, you know, I'm not, look, long life, and you can give patients a chance to have a longer recovery period if it's needed, then tracheostomies are a wonderful thing. You know, and again, I'm not opposed to them by any means. Right patient, right time, right place, you need a tracheostomy. But then the only place you can wean off the ventilator and the tracheostomy is ICU because of the skills that's needed. And another alternative is that's looking after long-term intensive care patients with tracheostomies, ventilation at home, as a genuine alternative to intensive care or to long-term intensive care. At the end of the day, it's an intensive care substitution service. So, and that service, intensive care at home, can provide similar care at home compared just by, you know, me talking about this for the last 25 minutes. You can see how complex intensive care is. And if you don't have a professional guiding you with this, it's very easy to get lost. Intensive care teams have agendas that go way beyond your loved one's prognosis and diagnosis. It's about, in intensive care, it's about managing beds, it's about managing staff, it's about managing their budget, right? It's about managing their clinical trials. It's often not about your loved one's best outcome. You know, that's just the reality. And you will need professional guidance if you have a loved one in intensive care. So look, that's it for today. Have a look in the next couple of weeks. I'll do another live session, and next time I will talk about end-of-life situations in intensive care, how to avoid them, how to get best outcomes and treatment for your loved ones, even if the intensive care team says they need to stop treatment. I will talk about patients' and families' rights in those situations, because you have them. Most families believe that intensive care teams operate in a vacuum, but they're not. They're not operating in a vacuum. You can challenge them with a service like ours, where you can get the professional guidance and the consulting and advocacy, so you can talk to intensive care teams on the same level. Because we are clinicians, you know, we know intensive care inside out. We can challenge intensive care teams, making sure that your loved one gets best care and treatment so that you can make informed decisions, get peace of mind, control, power, and influence. So that's it for today. I can be available. I am available over the phone. Just give me a call on one of the numbers that I just typed in the chat pad. Check out the article How to Wean a Critically Ill Home.com for mechanical ventilation and tracheostomy at home. And I'll talk to you next time. Have a good night. Have a good morning, a good day wherever you are. I wish you and your families all the best.